A very good afternoon, one and all, ladies and gentlemen, esteemed guests and participants. Today, we are gathered here on the important occasion on World Suicide Prevention Day. And on this particular day, we are going to join our hands to creating a hope through the action. So we have invited esteemed speakers today, and they are going to share their experiences and their knowledge to create a hope. And here at the end of the session, we are going to come up with a new action plan to creating a hope and to do some actions on preventing suicide. And as we know, this year theme is creating hope through action, reminds us all have power to make a differences. It's call for an action, and that we are going to do today. So without further delay, let me introduce our esteemed speakers today. First of all, I would like to thank the organizing team for this wonderful session, and also like collaborating partners of other college and other things. So first of all, I would like to thank IAPH Innovative Alliance Public Health and Santosh sir. He is the president of IAPH for triggering us or for supporting us to do such activities all the time. And also I would like to extend my thanks for Binu sir. He is always a supporter, and he joined us, and he is going to share his wonderful knowledge on this theme as well. And also Chitkara University, Mind and Sex Clinic Nagpur, and World Explorer YouTube channel. So I welcome all the participants behalf of all the organizing team. Can you hear me? Am I audible?
Yes, sir, audible.
Yes, right? Okay, fine. I welcome all the participants. So let me introduce the esteemed speaker. First, Mr. Binu Joy is the president of Nursing Scholars Society of India, and sir is going to discuss on dive deep into the theme of World Suicide Prevention Day. And the next, Mrs. Gagan Sharma, associate professor, Chitkara University, Himachal Pradesh. Madam is going to share about empowerment participant, that's saying a skill of assertiveness and saying no. And the next speaker, Mr. Palad Vinay Kumar, Senior Nursing Officer working in Nimans, Bangalore. And he is going to talk on gain insight from a mental health nurse who has worked with the client and the family members of suicide victims. Like he's going to share his own experience of such scenario. And Mrs. Kranti, child psychologist, works with Mind and Sex Clinic Nagpur. Madam is going to share about explore the unique challenges of suicide prevention in children and adolescents. It's one of the very important. And the next is Mr. Mallikarjuna, nursing officer, IAPH member, and he is going to talk about the uncover the latest suicide prevention strategies and legal issues. And finally, the coordinators, Ms. Simran and Ms. Ishu Rani, both are coordinators from the Chitkara University. And once again, I welcome all the esteemed speakers as well as the participants for this today's event. Without any further delay, I'll open the forum for the scientific session. First, I would like to invite Binu sir to take over. Sir, please.
Yes, a warm greetings to each one of you. Respected organizers, Santosh sir, Mallikarjun sir, Melvin, Mrs. Gagan Sharma ma'am, Mrs. Vinay Kumar sir, Mrs. Kranti ma'am, Mrs. Ishurani, Simran, and the whole team. The whole team who has worked together for taking an idle day Yes, life is very precious. Each life is very precious. There is always someone somewhere waiting for us. So only this is not the last way. Suicide is not an option. It never should be an option. Yes, of course, for that we need to come together. We as a healthcare workers needs to come together and create that hope. We should take forward. It's always together we can. So when we take hope to them, and our action should be always louder than voice. So this is the theme of the triennial theme, that is creating hope through the action. And yes, of course, we need to accept the reality in our own terms. And we need to move forward. As always, prevention is better than cure. And we should accept it as a reality that suicide is a major health problem and it can happen anywhere. So we should find out the cues. These signs we should be very, as an health career, we should try to notice out the cues or ideas. Many isolations. This all things should be noted out. So this year's theme is the creating hope through action. This theme reflects the collective effort of each one of us. When we are together, then of course we can prevent these suicides. And yes, awareness is the need of all. You cannot stop something without creating an awareness. So awareness needs to be raised concerns to prevent suicide. Because people don't talk about this. Usually youngsters and all, they don't talk about it. They keep that time isolated. They have some change of their usual behavior. So always we need to create awareness among the general public to remove the stigma associated behind these suicides. So that is a major concern, that awareness needs to be raised about the prevention of suicides, especially among the high risk groups. And majority of the suicide happens in the adolescents in the age group of 18 to 35. So when the suicide happens, when it happens, or usually this happens when you are your all the strategies, specifically the coping strategies fails. When you are not able to overcome a problem and your all the coping strategies has failed, now you have decided that it's the time. So we should make sure, we should try to enhance these situations, try to develop such a way that the coping strategies is enhanced, so that any of this who are having a thought of this suicides can overcome these stressful situations by making them aware of the coping situations. Yes, of course, whenever you notice such a person who is in danger of a suicide, it is best that we need to keep that person from, we should need to stay with that person. Don't keep them isolated. Whenever you are finding such a person who is chances of higher chances of suicide, it's always best stay with the person, be aware of his life, or be aware what is going his next step. Everything needs to be get aware so that we can prevent the immediate dangers of the suicide. The whole team needs to work out together. And yes, of course, whenever we counsel a client who is depressed or who's planning to go to suicide, it's always, our comment should be always non-judgmental and accept the reality that he's having a problem. You should not be in a judgmental way. It's always, whenever handling in such a situation, it's always a non-judgmental, and always we should be a supportive way. Provide him that yes, there is whole world of beautiful world is there. It's always there with you. There are many options available, so that needs to be stressed out. And yes, of course, we cannot neglect the professionals. They need to be aware there are professionals, encourage them. Your problems can be shared. It's not that it's only you can do. There are various professionals are available who can handle this. So encourage them to have a talk with the professional peoples. who can help them out, and always advise them to seek their support. It's not a harm to take a support. Encourage to help them seek, raise awareness. We need to create awareness. People don't talk about this because they think it's a stigma, like they may what the others will think, why I am doing this. So because of that, many of the people who commit suicide, they don't talk about this. So we need to create an awareness among the general public. More awareness needs to be created. And the whole team of these organizers who have done a very wonderful way to organize a national level webinar on the world suicide prevention is the right step forward to make awareness. Yes, life is very precious. This is the only biggest gift I think which we all have. So it's always the biggest gift to save a life also. So as an health workers, we all should take a step forward that it's only we can create hope through actions. Nothing can be done without hope is there. Always, there is always be optimistic, be pessimistic, there is always a life ahead. Like whenever in a situation when we fail anything and all, we don't have a cure for a certain disease, then also we keep at hope. Like in a cases of a chronic disorders, or like a cancers and disorders. So what we should be very open. We should be very optimistic. Yes, don't worry, there is a cure. Same way here also we should be very optimistic. We have to create awareness and create hope in the high risk groups that there is many things to do. When this many things they come to know that there is a lot of world, there is a lot of hope among when they get that energy. So we need to give them such a peoples needs to be a booster dose or a booster dose of awareness, booster dose of hope among themselves. So they are supported, they are not isolated. There are many peoples who are with them. There are many friends of the whole world is around them. They need to be, we need to put an energy or a booster of hope. With this, to create that hope, we have to create the awareness. We have to remove the stigma. We have to keep them engaged and keep them more and more motivated to share their ideas. So, and be non-judgmental in such a situations. That is the best way which we can move forward. So creating hope through an action is the greatest step forward. And I'm very thankful to all organizers who have taken this time to do the national level webinar on the same day itself. So the great effort of all the team members, I really appreciate the whole team behind it for doing this conference. Thank you, each one of you from the bottom of heart for inviting me to this August gathering. Thank you all.
Thank you, sir. Thank you so much. It's been a pleasure hearing from you, and your motivations and introduction to the theme is really enlightening us. Thank you so much, sir. Next, we'll hear from Mrs. Gagan Sharma, Associate Professor from Chitkara University. Madam has recorded her video, and just I'm going to share it for a while. So she has presented it. Everyone here, sir, can you hear? Hello, sir. Arjun, sir.
Sir, you are audible, not the presentation.
Sir, play the video.
Okay, okay.
You haven't played the video till now.
No, I played the video. Can you hear?
No, not audible, sir.
Not audible. Okay, let me. Can you see the video now?
Yes, sir, you are able to see.
Good afternoon, everyone. I'm Gagan Sharma, Associate Professor at Chitkara University.
Is that audio fine?
Yes, sir.
Yes, sir.
University College of Nursing, Himachal Pradesh. I would like to congratulate Innovative Alliance for Public Health to organize national webinar on creating hope through action in celebration of World Suicide Prevention Day. With collaboration of Nursing Scholar Society, Chitkara University, Himachal Pradesh, Mindsex Clinic, and World Explorer of India. I would also like to thank organizing committee for giving me this opportunity to share my thoughts on assertiveness and how to say no. Assertiveness is the art of expressing your thought, needs, and boundaries with clarity and precision. It allows you to communicate effectively, ensuring your message is understood without ambiguity. Being assertive means having the confidence to stand up for yourself and assert your opinion, right, and desire in a respectful manner. Assertiveness empowers you to speak up without fear and hesitation. Assertiveness promotes healthy conflict resolution by addressing issues directly while considering the feeling and right of others. It strengthens relationship both personally and professionally. Assertiveness. So what is the meaning of assertiveness? Assertiveness is a communication and behavior style characterized by confidence, self-assured expression of one's thought, idea, feeling, needs, and boundaries, while respecting other rights and perception. So assertiveness is helping to express ourselves openly and honestly, positively and confidently in front of others, and simultaneously we are respecting the others' rights and perception. Next is a communication style. We are having a 4 communication style: passive communication style, passive aggressive communication style, aggressive communication style, and assertive communication style. The first one is the passive communication style. The passive people are emotionally dishonest, indirect, inhibited, self-denying, always in apology section, always blaming others, whatever is happened in the life. They are just taking care of others' need, their values, their expression, their feeling, but they are not taking care of their own values, belief, and feeling. Next is the passive aggressive communication style. These people are emotionally dishonest, indirect, self-denying at first, self-enhancing at expenses of others. They are not meeting the needs of other as well as their own. Next is the aggressive communication style. These kind of the people are inappropriately honest, direct, expressive, attacking, blaming, controlling other people, but self-enhancing at expenses of others. They are just thinking about their own feelings, their own values. Last one is the assertive communication style. Assertive communication style is the people are appropriately honest, direct, self-enhancing, expressive, self-confident, empathetic to emotion of all involved. They are taking care of their own values as well as others. Here I quoted with one example. Imagine you are standing in line at the hospital laboratory to give blood sample and someone else pushes in front of you. Aggressive response could be to grab them by the shoulder and say loudly, "Hey, what makes you so important that you don't have to wait in line like the rest of us?" This might make you feel better in the short term, but you will probably also spend the rest of your hour feeling annoyed about the interaction. Perhaps the other person will shout back at you. The situation will get even worse, really leaving you in a bad mood. For the same scenario, the assertive response could be to gently tap the person on the shoulder and say in a clear but respectful voice, "Excuse me, there is actually a line here. It would be better if you could wait for turn like the rest of us." You may get a more positive response to this. Perhaps the other person will apologize and move to the back of the line, or they may explain their reason for wanting to push in, and you may feel happy to do them a favor. This may still respond badly, like your assertiveness does not guarantee other will not be aggressive, but at least you will feel good knowing that you did your best and used assertive communication. Next is assertive communication tips. Here there is a one cycle: emotion, what you did, the behavior, situation, and how assertive answer you have to give. There is a two person. The one is feeling disrespected. Why? Because other roomie is on phone at night. Because the first person was trying to sleep. How to express in an assertive manner? I would like you to text instead of talking after 10 p.m. in a polite manner. There is a husband-wife. Wife is feeling uncomfortable. Why? Because husband brings someone home for dinner. Situation was among husband and wife. Wife is saying, "You did not talk with me about it first." What could be the polite answer? "I would like to know your plans ahead of time so I can make plans accordingly. I feel anxious." There is a research team where there is a one leader of that research activity. He is very anxious. Why? What was the behavior? When we don't discuss the progress on my research at our weekly meeting situation. So I would like us to discuss about research, or we'll spare some time for discussion regarding the research during meeting. This slide shows the component of assertive behavior. Eye contact, then body posture, their distance, physical contact, gesture, verbal and non-verbal gesture, facial expression, voice tone, fluency, timing, and content. That all the components make a assertive behavior. Next is how to say no. It's a great difficulty saying no to others. Even people who are quite assertive in other situations may find themselves saying yes to thing that they really don't want to do. For example, in workplaces. Now saying yes to something you don't really want to do can be appropriate in some situation. Here is one scenario. If your boss asks you to do something and you don't really want to do it, that would not be appropriate, and practice your assertiveness skill and say no. You may get sacked. What are we talking about here is if you find yourself saying yes in other situation, for example, if a friend asks you to do something which is a real inconvenience for you and you say yes, or if you find yourself voluntarily or for all sort of jobs to the point that you are overloaded. Outcome of not being able to say no. The first thing is the person who is saying yes when really means no. Resentment, like resentment is nothing but it offends the emotion of the person. Okay? Resentment and anger can build up towards that person who has asked you to do a favor. But there is no mistake of that person who is asking for the favor. But you are the one who is not saying no, but you are, instead of no, you are saying yes. That is increasing frustration and disappointment among you. It is like when you are having a coping mechanism, using a coping mechanism, then what will happen? You will be overworked and highly stressed. And for a long term, when this condition is going on in the process, then what will happen? The person have a decreased self-esteem due to the increased frustration, and it may lead to the depression and anxiety. As well as they are having some physiological issues also. The person may have a high blood pressure, may increase the blood sugar level, and maybe towards the cardiovascular disease condition. You just see that because of your communication style, you are land up with some psychological and physiological condition. At the other end of the spectrum, some people are able to say no, but do so in aggressive manner without consideration or respect for the other person. This may result in people disliking you or being angry and resentful. Neither of these situations is good assertive communication, right? So here I'm having unhelpful belief about saying no. As you can see that, like from the childhood, the teacher and the parents are convincing us like no is rude and aggressive, right? No is unkind, uncaring, and selfish. Saying no will hurt and upset others and make them feel rejected. No to somebody, they won't like me anymore. Others' needs are more important than mine. I should always try to please others and be helpful. Saying no over little thing is small-minded and petty people. These are the belief which is inculcated during our childhood. They are just concluded it is very rude and aggressive. Small-minded people are saying no. Changes of thinking. When we are changing, when we want to say no, then we have to say no, but in a polite manner. People have the right to ask, and I have the right to refuse. When saying no, are refusing a request, not rejecting a person. When saying yes to one thing, actually saying no to something else. always have a choice and constantly making choices. People who have difficult saying no usually overestimate the difficulty the other person will have in accepting the refusal. That is what happened. Like, if my friend is asking a favor, then what I will do? I want to say no, but I don't want to say no because she's my friend. If I don't agree with her, irrespective of that, I have to say yes because I have to take care of her feeling. Because I know ki like if I say no, he may be offended. Why I have to think much? Right? If she is having right to ask a favor, I'm having right to say no. Okay? So there should be no overestimation of the feeling of the other people, those who are asking for the favor. By saying no to somebody, it allows them to say no to your request while still being able to ask for further request. How to say no? Be straightforward and honest, but not rude, so that can make the point effectively. As a rule, keep it brief. Tell the person if you are finding it difficulty. Be polite. Say something like, thank you for asking. Speak slowly with warmth, otherwise, no may sound abrupt. Don't apologize and give elaborate reason for saying no. It is your right to say no, right? If you don't want to do things, remember that it is better in the long run to be truthful than breed resentment and bitterness within yourself. Because if you are saying yes instead of no, it creates a frustration within you, right? To avoid that bitterness created by this yes, you just in an initial phase you just said no. Saying no, take responsibility for it. Don't blame or make excuses. It's your choice. If you don't want to do, then don't do, right? But don't make excuses and not blame other people. Why? And don't blame the situation. Change I can't do, I don't want to do. Like aggressive people will say, passive aggressive people will say, I can't do that thing. But being assertive, you just say, I don't want to do. There is a Trevor Powell who gave the 6 ways of saying no. Direct no. First one is the direct no. Direct no is nothing but someone asks you to do something you don't want to do. Just say no. Reflecting no. I know you are looking forward to a walk this afternoon, but I can't come. That is known as reflecting no. Reason no. I can't have lunch with you because I have report that need to be finished by tomorrow. Rain check no. I can't have lunch with you today, but I could make it sometime next week. That is rain check no. In the rain check no, there is a surety to do the things in a next time. Inquiry no. Is there any other time would you like to go? Then broken record no. Means repeatedly you are saying no, no, no. Means you want to say no and you are still on a no. Like here, Tom is saying, no, I can't have lunch with you. Jerry? Oh, please, it won't take long. Tom, no, I can't have lunch with you. Jerry, oh, go on, I will pay. Tom, no, I can't have lunch with you. Like person is determined. No, I don't want to do this thing. So I don't want to do anything. But if the person is manipulating that person, again, the person response is same. That is assertiveness. So assertiveness is a skill. Like any skill, it takes practice to get good at it. Like the nursing procedure, it's a skill. If we are doing again and again, we will good in that. This is the list of references which I used for preparing my material. Thank you so much for listening.
Thank you, ma'am, for your time in recording this session, and in spite of your busy schedule, and at least you have put on a lot of effort to record this video, and it was a wonderful presentation actually. Thank you, ma'am. And the next I would like to call Vinay sir, senior nursing officer, to share his experience. Sir, please take the.
Yes. Can you hear me?
Yes, sir. Yes, sir.
Okay.
Could you please, yeah. Yes, sir. Yes.
Yeah. Good afternoon, one and all joined here. This is a day that we are just observing that many people have lost their life because of suicide. Although it is very easily preventable, there are many preventable causes for suicide. So in this context, I would like to thank all the organizers, especially representatives from IAPH, and I would like to especially thank Santosh, Melvin, and Sharma ma'am, whom she has taken effort to getting into understanding of assertiveness, what it is required, because it is directly linked to prevention of suicide. When we see suicide as a behavior, when we see suicide, it's an outcome of many complexities that individual experiences in various day-to-day life experiences, starting from the child who grows up to the level whatever they grow. Every experiences that they go through the matters, how to handle the thoughts of suicide. So I would like to apprise you in this session regarding what are the experiences that I have seen while treating the patients who have been under my care for the past 10 to 12 years at NIMHANS. First and foremost thing, whenever a patient is being approached to under your care, important thing is we should have certain skill sets of counseling to handle the patients is very essential, because right from the basics of this skill sets, it is essential that that establishing the trust, which itself gives that the cues of suicide could be understood by us very easily, and we can prevent those things. So, as a interviewer, as a counselor, as a therapist, so it is our own strengths and abilities also matters in identifying the patient's risk. So I would like to categorize in three different areas in prevention of suicide. One thing is we have to identify the risks which are experienced by the persons who are thinking about suicide. What are the possible risks? Second thing is we have to identify and minimize the risks, modify the risks so that we can prevent suicide. Third area that I would like to cover is managing the suicidal attempts or managing the suicides. That is also another part. coming to the first part of it, which I would like to brief you regarding this now. First end is identifying suicidal risk is very essential. So who are at risk? How we can identify the risk? It starts with our basics. So when a patient comes to our contact, so first, like we will go for collecting history. Generally, that they will not reveal everything, whatever they experience. Like I have this problem, I have thought this problem. No, they will not reveal everything in a span. But it is a skill of an interviewer who gets into this and gets into depth of it and to get the information from the patient. That is very essential. So it becomes a skill of the interviewer takes precedence rather than the information, the way that we have, whatever we have. Because whenever patient comes, they require hope. Just now, as it is, we have discussed. So hope, it cannot, it can be instilled within a span of 1 to 2 minutes, provided the way of handling, the way of interviewing, that will give right directions to the patients that they will express themselves. So when we are collecting the history of the patient, so they will start expressing that we have to go with the minimal basic things. What is he doing? Why he is? What is his work? Where he is working? Whether he is a student? Yes, okay. Then what made you to come to the hospital? Rather than having to the more of specific things, we have to ask about what are the mode, what made them to come to the hospital. Through their mouth itself, we have to start interviewing. Then it should be linkage. Basic concepts of history collection should be linkage towards the end of it, that is suicide. So they themselves has to say that they are experiencing these issues. Once they themselves say that they are facing these issues, that can be interviewed. So while interviewing, we have to concentrate upon few aspects of history. One is how is his mood for the past? How is his mood for the past so many years? How is his mood for the past 6 months? How is his mood for the past 3 months? How was the day yesterday? So that is not taking mood of it. And what is the personality? What is that accommodation behaviors? What are the social skill sets they have? What are the friends they have? How is the working environment? If they are working, how they are? And how is that performance in their studies? Whether they have experienced any recent challenges in their life situation, any changes in their life situation. These are all takes them. We will get the hints about that. Yeah, this stage that they are. There could be suicide as a hint. Every patient who visits us, it should be interviewed, keeping into suicide as a backup phenomena in our intellect. Then we have to interview generally along with that every aspects. So what is that behavior? Whether they are dull or depressed, that behavior also hints at. And when we do physical examination, many hints also we will get to understand. So is there any injury over our body marks? Any ligature marks on the neck? Any burn injuries that they had experienced? Whether they have any fall injuries, any fractures. Of course, these are all, it gives hints about whether it's a possibility of suicide. Whether any burn injury over mouth because they would have consumed any harmful substances. That's how, while history collecting itself, physical examination, history collection, mental status examination will give hint for many things. Foremost thing that we have to understand is cognitive functions. Especially with these patients, they will have depressive cognitions. They will lose hope, hopelessness, helplessness, and worthlessness. So when we reach to the point that they express these, they will definitely verbalize us that what are all the thoughts they have, thoughts of suicide, that I am getting thoughts of it, and thoughts of the method of committing suicide, thoughts of the way, the strategies that they have already made. They will fix the date. There is many examples that they will fix the date, time, everything that they will plan. They will have a specific suicidal plan. They will also make specific plans of method of committing suicide. So these are all they will definitely express when we have definite good experience, skills of interviewing. So when they express, it should be taken care of with sensitivity. When we are sensitive to the thoughts of suicide also, then definitely they will definitely help us. They will receive support from us. It will help us to intervene at that stage, and we can prevent suicide at that phase also. So coming to the point, in minimizing risk, after we identify many risk factors, we have to minimize the risk. To minimize risk, there are environmental changes that is required. Whenever a person is there are certain changes are required in the environment. We have to get away with all the sharp objects, whatever is there in the surroundings, so that they can think about the thoughts of suicide are not increased or minimized, or that it is substituted. We can minimize exposure to harmful substances, chemical substances like phenol or whatever it may be, which are harmful, that they are potential for consuming. We have to minimize loose clothes, threads, ropes, whatever is available, we have to minimize. We have to ensure that fans which are not low lying, it should be very high. And especially the wards, the psychiatric wards, which are, it should be ground floor. It should be avoided to have 3 to 4 floors. The standard guidelines which says that ground floor is more appropriate than any other floors. So having ground floor, which will benefit, will prevent jumping from the top of the buildings and committing suicides and all. So coming to the point that environmental modification also plays a vital role in preventing suicide. So after minimizing committing, there are, even though after we minimize, we try, we attempt many things, patient may tends to go for suicide attempts. Suicide attempts has to be measured based on the lethality and intentionality of the attempt. There are 2 tools which is readily available. We can go through it. So what is the intentionality is the level of commitment that a person is having to commit suicide, attempting suicide. When is there any lock which is put in the room, that lock is very strong. Is there any specific plan which is being made and that is being implemented? The level of intention, that whether they have written any suicide note, everything which matters. So based on these criteria, the intentionality of the suicide can be assessed. Coming to the lethality, patient who has already attempted, whether it is a simple exposure to the suicide attempt or the exposure which has caused the harm, which is difficult to save the life itself, or it is mild or moderate. There are certain criteria which needs to be assessed. Based on that, we have to assess the lethality of the suicide. So generally, a patient with high lethality and high intentionality definitely requires close observation. The observation which is eyeball to eyeball observation, 1-to-1 observation. So these patients have higher chances for going for another re-attempt of suicide. So coming to these points, I have taken an effort to bring to your kind information that, see, these are all patients who have experienced it, how to manage these things. when a healthcare settings. So I hope you got into some concept of it. This is with concept the patient as a centric. Apart from patients, there are other dimensions to look after is the relatives, the patient caregivers who are involved in the care. So we have to ensure that patient relatives are being informed about the attempts, sharing the information, the modes, methods, the strategies that they have taken, already had planned. What are the possible risks? Involving the patient relatives in the care of the patients will double the chances of minimizing risk. Coming to the community also should ensure that they should pass so many legislations, they should make the policies, they should ensure that laws are passed, they should see that many preventive strategies within every organization, so we can prevent suicide. So we can hear to that many peer groups, peer who is above, like a person who is a second year, who can be a peer to the junior, just enter the college. So peer counselor, that will benefit rather than a teacher counseling a student. See, we have to see that many different strategies can be evolved so that we can prevent many suicide. One thing what every patient benefits out of intervention is non-suicidal contract. We have to establish that trust. We have to make contract with directly with the patient that these are all things. You are thinking about this suicide. You have specific plans. So I assure that whatever that you require will be assisted by us. Let's make a contract that you will not go for committing suicide in future. If such thoughts are arising, you will be communicating directly in words to me rather than cues. That such type of suicidal contract, non-suicidal contract with the patient definitely will help, and definitely many things whenever we made a contract, they will come and they will say and they will definitely express that I am feeling of thoughts of suicide, I am feeling of such thoughts of suicide, I am getting thoughts of suicide. Definitely we will intervene in this matter. So I take this opportunity again. I would like to thank all the organizers for giving me opportunity to brief on my perspective. And I would like to thank all my panelists who have joined here for this. And let's work on preventing suicide in societies, as by generating more hope, we can definitely win every patient's confidence. Definitely we can assist as a therapist. Thank you so much.
Thank you, sir. Thank you so much for your practical experience, and especially the assessment part. It's very important to identify the cases. That really helps. Thank you, sir. Thank you so much. Next, I would like to invite Kranti ma'am, child psychologist, Mind and Sex Clinic, Nagpur. Ma'am, please take over the dais. Ma'am, please. Yeah.
Hello, everyone. Am I audible?
Yes, madam. Yes, madam. Yes, you are audible.
Good afternoon, everyone. Good afternoon, respected speakers. First of all, I would like to thank Vinay sir for such an extensive session. I myself have gained a lot of insights from his lectures. And I would like to extend my gratitude to IAPH. Santosh sir, thank you for providing such an excellent platform for such a sensitive issue. Is everyone able to see my screen? Malik sir?
Yes, ma'am, we are able to see.
Okay. So I'll start with my presentation. The topic which is assigned to me is unique challenges in suicide prevention, especially in children and adolescents. So what we mainly focus is, as a society, we are mainly cognizant of tangibles like such education, physical health, and building national human capital. Emotional well-being and psychosocial support uh, many of the times takes backseat, right? There is a lot of stigma attached to mental health also. Suppose a person is suffering from any depressive thoughts or low mood since a couple of weeks, the person will not could say okay, the person will not reach to the psychiatrist or psychologist unless and until he has definitive thoughts of not going out of the house since 15 days and avoiding daily routine. Then someone will push him to visit some mental health professional, then the person will think of visiting the mental health professional. That is what is happening in suicide ideas also. I'd like to throw a light upon some statistics, especially childhood suicide over worldwide. For youth between ages 10 to 24, suicide is the third most leading cause of death. And this data is according to CDC, Center for Disease Control. Nowadays, more and more teenagers are dying from suicide rather than physical causes like cancer, heart disease, AIDS. All these causes are, we have overtaken them, and now the suicide has become the more and more causative factor for the deaths of young children. Each year, over 5,000 suicides attempts are recorded. These are all worldwide statistics. Now, let us give thought more of Indian perspective. Childhood suicide statistics from Indian perspective. I could collect data from NCRB, that is National Crime Records Bureau, which says that right from 1978 to 1990, there was rise in the suicidal attempts from children. There was actually 41% increase during these 10 years, 80 to 90. Then also it is seen that highest rate is among 15 to 29 years of age group, followed by 30 to 44. That's why I guess I have been assigned topic, especially for childhood suicide topic, because it is seen that later childhood, late adolescent age group में the suicide rates are more and more increasing, in India especially. See, average 31 children died by suicide every day in India, and these are the latest 2020 statistics I could recollect. Again, 11,000 children died by suicide in 2020. That is 18% rise from 9,000 to 9,400 in 2018 and 19. That is why we need to discuss specifically from child perspective, childhood suicide. Why we are focusing on childhood suicide is because of this, because there are rise in cases. So I'd like to start with the introduction to suicidal ideation. What is suicidal? Most of the topic, I guess, Vinay sir has already thrown the light upon. I'll just brush it up. See, suicidal ideation and risk assessment, there are two different terminologies. As a psychologist, I need to assess. The assessment is main part from my perspective. So I need to assess the risk of suicidal ideation. So first we'll see what is suicidal ideation. Suicidal ideation is actually maybe suicidal thoughts. Some person is thinking about planning suicide. Now those thoughts can range from slightest, the thought is just crossing my mind, or to the extreme level that I am actually planning the day, the time, or the place where I'll be committing the suicide. The thought ranges, it is like a spectrum. The slightest possibility of suicide till the extreme spectrum, where the person is planning actually where to do the suicide, when to do, and through what means the suicidal can be planned. So suicidal ideation is basically thoughts and means of thinking about planning suicide. Some people may experience suicidal thoughts once in their lifetime, as I said earlier, while others may experience suicidal thoughts on a routine basis. Especially it happens on MDD cases. Even daily basis, they are not happy with their daily life, or some stressors, some or the other stressors are there, and the coping strategies fall, and then they start getting repeated suicidal thoughts, and that is when they should actually seek help. But this does not happen, unfortunately, and then the suicidal ideation or suicidal thoughts actually result into suicidal behavior. So what comes next step is, suicidal ideation risk assessment. It is actually a process of determining how seriously someone is thinking about or planning for a suicide. Now, why there is need for risk assessment? As Vinay sir has rightly mentioned, that unless or until we assess how intensively or how lethally the person is thinking about suicide, then only we can plan of some action or plan of some interventions. That is why this is the basic and utmost important. Risk assessment is a process of utmost important. It takes 5 steps: identifying risk factors, identifying protective factors, and then actually conducting direct suicide inquiry. I guess this is the being psychologist, this is where the challenges reside. In third step, actually conducting suicide inquiry, and later on determining risk level, and depending on the risk level we should decide or determine the interventions. So I will see one by one, and I'll again pose where actually I face the challenges practically conducting the suicidal inquiries. I guess everyone, I'm not very fast. Malik sir?
Ma'am, please. Yes, ma'am, please proceed. It's okay, ma'am, please proceed.
Okay. So I'd like to discuss a case study. Recently, one child visited my clinic, child aged 14 years, presenting with increased irritability since couple of months, being impulsive at times, and child used to shout at parents when spoken to directly. He also denied going to school. The child never visited school in 2 months. He also did not want to talk about the current issue. Whatever the issues were going on, the parents had no clue why the child is behaving suddenly in the manner he was behaving. And also he was not ready to talk with grandparents also, or not with friends also. So the parents took him to clinic. See what I don't know. We don't know what is going on with him. Since 2 months he's not going to school, not talking to us. If we are inquiring something, see, he just shouts at us. So here, nowhere it is obvious that the child has suicidal thoughts. As sir has rightly mentioned, for every case, each and every case, especially teens, I, as a psychologist, always have that thought behind my mind that I should screen it for the suicidal ideation. So here are the challenges. The challenges actually reside in identifying the suicidal tendencies in children. Because why? Because adult directly can speak like, I am feeling depressed, या मुझे बाहर जाने की इच्छा नहीं है, that I don't feel like continuing my daily routine. That can directly give you a hint that the mood is depressed, and then later on we can directly modify our session accordingly. But in case of children, the children present with symbolic representation, like the earlier case I said, parents bought the child with not going to school and increased irritability, wherein no one can suspect that the child might be having suicidal thoughts. That is the main challenge we face, that children present always with symbolic representation rather than actual complaints. So major hindrance in building therapeutic communication, wherein child feels trustworthy. See, in session 1, I cannot directly talk child regarding whether you are having the suicidal thoughts, or you're having low mood, or why you're not talking to your children. If I start asking such interrogative questions, the child, that will become major hindrance for my therapeutic relationship. The child will not trust. He will feel that he or she will feel that the madam is already biased opinion, so I'm not going to share at all. It is like that. So major hindrance is building therapeutic relationship, therapeutic communication. The child should trust you that he or she should open up to you about his thoughts. So for that, what we can do is treat children as miniature. Many of the times, parents mistaken here only. The parents think that always, like जैसे मम्मी, हर एक मम्मी को उसका बच्चा हमेशा बच्चा ही रहता है. Even though the child is 18 years, the child is child only for mother or parents. So what they do sometimes is mistakenly, they treat children as children only. They don't treat them as growing adults or as teenagers. They don't inquire or talk to them as in they have their own opinion. They just they just bombard their own thoughts onto the children. And there is less of listening on part of parents. That is where they go wrong. And that is where we as a therapist come in, because patience is the key. Sometimes interview prolongs as the child does not open up. That's why we need to be patient. We need to talk about their daily routine, ask open-ended questions like, do you know why you're visiting the hospital? Here, I agree that I should not probe the questions interrogatively, but the question should be framed in such a way that the child should feel that his opinion is valued. At the same time, I'm not interrogating just like a police officer, why you are behaving like that. Getting it? So, starting with the risk factors, we should identify risk factors like trauma, triggering events like leading to humiliation, shame. For example, I'd like to share one example here. Uh, One child was there, fifth or sixth standard child, wherein they had some birthday party at child's house, and the said girl was not allowed to visit the birthday party. Maybe reasons were different. The parents were not comfortable with the timing of the party or whatever. But then on the very next day, because the child did not attend the party, the bullying started from classmates, that you are very princess, and your mother is not allowing you to visit the parties, and you are not grown up, or you don't have any say at home. And the bullying continued for a couple of months, then 3 months, then 6 months, and at the end of 6 months the child started avoiding going to school and then lined up to the therapist. So triggering events should be noted. Underlying mental health issues, especially in case of children, uh, there is some genetic predisposition, or there are some underlying mental health issues which are not easily recognized by the by the treating physicians or doctors, or whoever the family doctors are there. Then history of substance abuse, medical health diagnosis, newly diagnosed. For example, if the child has come to know that his mother is recently diagnosed with CA breast, and which is life threatening disease for the mother, the child definitely has effects of it. Definitely he or she is going to go into depression, or he will start feeling need to be with mother, and then he avoids going out of the house and everything. These are all actual cases I am in between putting into the as and when the presentation comes. Then any significant change in mood of children is a high risk factor for the suicidal ideation. Sometimes children are contributing to the interview actively. Other times they don't want to talk or share any information. Like in earlier case, the case study, same happened with me also. The child was not at all ready to share anything. For 20 to 25 minutes, we were just sitting, and I was just encouraging child to draw or color or whatever he or she wants to do. I just allowed him, yeah, you take your time and you just be relaxed, and whenever you feel ready to talk or ready to share, let alone share, whenever you feel ready to talk anything other than this issue also, we'll start. So I waited for half an hour, and then the child started. Like he started with school issues, that I am good at studies, but still the colleagues are not friends with me, and so on. So wait until the child is comfortable sharing the information. That is the key. No need of hurrying into the direct inquiry, even though the direct inquiry is necessary. Until you are sure the child is comfortable with sharing the information, please wait. Let the child know he or she is heard, that his opinion has values. Then another case study, the earlier case study was of 12 to 14 years of age. This is more of adolescent. A case study of a gifted adolescent female who took her life at the age of 18 using firearm. This is actually ex post facto inquiry, or you can say psychological autopsy, which was conducted after the child had committed the suicide. The study was conducted to explore the factors which were the positive or predisposing factors why the child must have resorted to the suicide. The personal, environmental, and cultural variables that may have contributed to her suicide were examined. through interviews of family members, original documents, and other artifacts, including a videotape that was a compilation of events throughout the subject's life. The purpose of this psychological autopsy was to determine what factors led her to end her pain by choosing death over life. Now, in this case, what had happened was this was a case of cyberbullying. The child was extremely gifted. Her IQ was 140 on our standard IQ tests measurements, and child were performing very nicely. But maybe sometimes it happens that if person is doing good in one area, maybe she was not very good with social communication or not very good with reciprocal communication. That's why, but the kids were unable to understand it, and they were taking it other way around, that the because she's intelligent she's not mixing with us, or because she feels that she is superior, that's why she's not mixing with us. And one incident happened at school wherein she was videotaped, and the same video was circulated through the school throughout the standards, and then the text messages were there by kids, and actually cyberbullying started. And at the end of maybe year or so, the child did not talk about the incidents, not with the parents nor with the friends, because as it is she was introvert, and the parents also did not got hint from child's changed behavior, and they did not resort to the mental health professionals, and eventually the child resorted to the suicide. So in case of teenagers, teens are manipulative. It is very difficult to take out the information, or it is very difficult to make the teenager speak, or they can easily refrain from sharing the thoughts. They can easily manipulate the data, like हाँ school गए थे मैम, but then school में तो कुछ पढ़ाया नहीं, so that's why I don't like to go to school. They can easily manipulate, and it is up to you, it is from your clinical judgment, that you need to decide whether the child is manipulating or whether the child is actually telling the truth. For that, we always ensure that we conduct interview with parents, caregivers, and guardians, so that just to cross check the information which the child is providing. Okay. So third step is direct inquiry about the suicide. What we actually do is we talk about suicidal ideation. That is, have you ever had thoughts of hurting yourself or others? Have you thought about ending your life? This is related to ideation, thoughts, actual thoughts. And then step number 2 is planning of suicide. And then the behavior, suicidal behavior, whether the ideation has become resulted into any plan, sort of like I will go to that river and then I will jump into the river, that comes under planning. And then whether the child or whether the teenager has actually tried or suicidal behavior in the past history. Now for this, there are standard assessment tools which are available in the market. Usually, as a practitioner, we prefer Columbia Suicide Severity Rating Scale because this is very thorough. It takes around 30 to 40 minutes to administer the scale, and then the scale gives us, after analysis, the scale gives us the severity level of suicidal thoughts. The severity level can be mild, moderate, or severe. Now, depending on the severity, depending on the risk assessment level obtained, high, moderate, or low, if the severity level which I obtained for, say, case number 1 was, say, moderate. So using my clinical judgment, I should decide whether the child needs admission or only the means reduction. Means reduction means, as the Vinay sir has rightly said, that any harmful material should be kept out of the reach of the child, or there should be the child should not be left alone maximum time, and develop a crisis plan. The emergency number should be provided to the child. If there is low risk which is obtained, the child can be managed on outpatient psychiatrist referral just for the time being, because the impulsivity has to be reduced, and then we take child for the CBT or cognitive behavior therapy sessions. Of course, high risk, if the child falls under high risk, hospital admission is recommended. Now, what interventions we can do? Why do we do risk assessment? Is to just to take some kind of interventions. So, what interventions? These interventions are specifically for case to case basis. Now, for larger scenario, interventions at public health department level, what we can do is we can take universal strategies like advocating for funding for suicide prevention programs and education, promoting mental health parity, promoting education on suicide prevention. That is basically creating awareness. Those all fall under universal strategies. Then selective strategies will be skill development training for the mental health professionals, and continuing education for mental health professionals as and when it is required. Then indicated strategies will be requiring effective brief interventions for youth with suicidal ideation or behavior, promoting resources for continued recovery for at-risk youth, such as support groups. We do have, like we have alcohol anonymous groups, we have suicide anonymous groups, NGOs working for them. Then at Maharashtra level, we have state level suicide prevention cell. The teleconsultation is 24/7 working. The number is 104. And we have small organization working for tele-counseling cell called Telemanas. These are the numbers displayed on the screen. Now, involvement of caregivers, pillars, you can say family, schools, and friends. These are the main pillars, because in case of children, the suicide is not, only children are not responsible for their actions. In case of suicidal ideation or suicidal behavior, especially for children, only children are not responsible. I always feel the caregiver pillars are more of, they have 50% say in the childhood suicide ideation. Like family members, what they can do is monitor and pay attention to your teens, peer groups, and social media sites. Spend time with your teen and be involved as much as they will let you in their social and sports activities. Tell them and demonstrate that you love them. Increase the emotional acceptance for them, especially dads. When there is a adolescent boy in the house, the dad should be more open to the child or boy, because boys don't feel easily open. I mean, they don't feel easily. Either they don't feel comfortable talking to mothers, especially. This is what observed from my clinical experience. Then, in case of schools, what teachers should be there? Teachers should be vigilant if there is any behavioral change in particular child, like isolating from friends. The child was earlier very happy-go-lucky, used to participate in every activity, and suddenly there is change. Suddenly the child is keeping mum. Suddenly the child is not taking participation into competitive examination. Suddenly, child has stopped coming forward for activities, or child is giving his valuable things to his friends just like that. What friends can do is, friends are the best judges to, they are the first ones actually to notice if there is any social withdrawal, if the person or the adolescent is resorting to some sort of addictions. The friends will come to know first, then the family will come to know, and then the school, and then the, at the last, I mean, by the time the child reaches to the therapist, by the time the child reaches to the mental health professional, he or she have already committed or tried one a couple of times suicidal behavior, and then only they reach to us. So family, schools, and friends can be more vigilant for any change in the behavior. Now, what we can take home message for all our viewers is, I really feel to think, give a pause and think whether we are into a failure as a society model, because children are supposed to be happy and joyful. Still, they are not for all sadness, let alone suicidal ideation. I mean, we are unable, are we unable to provide safe and sound environment to the children? This is really an issue we should think upon. And I would like to stress the message that adults are responsible for their own actions. Many a times they have little bit of insight that they need to seek help. But in case of children, the suicide is multifaceted. There is absolutely no insight of seeking help. They don't feel that there is something wrong within them. And their actions, the suicidal behavior is just impulsive reaction to the stressors. Stressor may be change in the school environment, change in the family member, I mean, the marital discord of the parents, their children's suicidal behavior is always an impulsive reaction to the stressors. And of course, society, family members, school environment should play crucial role in childhood emotions, identifying the childhood emotions, so that early identification will result into early seeking help. Thank you. I'm hope I have thrown some light onto the topic and did the justice.
Thank you, ma'am. Thank you for your wonderful session. There are a lot of questions from the participants. Any of we one more speaker is left. So once Mallikarjun sir finishes talking, then we'll open the forum for doubt clearing and
Sure,
other
sir.
things.
Thank you, sir.
I invite Mr. Mallikarjuna, nursing officer. Sir, please take over.
Okay, thank you so much, sir. I hope my screen is visible to all.
Yes, sir. Put it in presentation mode, sir, please.
Sir, this is a PDF. I will share like this only.
Oh, okay, but it
Okay.
looks. I think you can maximize the.
I can
PDF.
maximize. That is okay.
Yeah, yeah. This is.
Is
fine.
it okay
This
now?
is- yeah.
Okay.
This is fine.
So my topic is suicide prevention strategies and legal issues. Thank you so much, everyone, for joining the session. We have more than 660 registrations, out of which we are able to see half of them in the presentation today. This is so much more than expected what we had. So on this day, we have covered majority of the topics, like the most important topic of assertiveness, how to say no. This is the one thing, if you are able to practice, you will get rid of majority of the stresses in life. And some other topics also we have discussed, the experiences, how to prevent suicide in the hospital settings, etc. Now in this topic, I want to focus more on primary prevention. So how we can end it in the initial stages itself. So now all the previous presenters has presented that what are the reasons for suicide. There may be depression, there may be health problem, there may be addiction, or there may be stress on the person, etc. So if any person is having such of symptoms, or if they are facing any of such situation, we are not able to share to our friends or to family members, or to the near and dear ones. If we are not able to share, that means we are internalizing the situation, which will create a lot of anxiety in ourselves, and also it will cause more stress on ourselves. So focus is to be on the self-reporting behaviors. It should be everywhere. It can be in the family, it should be in the school, it should be in the college, it should be in the workplace. So as in the previous presentation, ma'am has said that no one is ready to share immediately. So why they are not able to share? The reason is, there is everywhere we are having some of the barriers, like a senior, junior, teacher, student, or most respectable person in the family, and the least junior person in the family, etc. So if we are able to overcome these barriers and allow open communication in between everyone, and if we are able to speak, and if we are able to support each other, then only this is possible, which will not happen in a day, because majority of the times culture plays a vital role. Some of the topics we doesn't prefer to speak in public, and some topics we speak in public. So how, if we are not able to speak in public, but we want to say it? So that is the reason we have took the topic of assertiveness in the starting phase. So how we can tell the things which even we don't want to say, or how we can say the things, say no also when we don't want to do the things. So that is what we focused on this day. And next thing is social media. Social media is playing a vital role in creating stress among the children and adolescents. What is happening is, nowadays everyone is addicted to the mobile, and they are just seeing the mobile, and they forget all the time. And if they forget the time, that is also okay, but is it causing any behavioral change to them? Nowadays, we are seeing so many influencers in the social media. Like they may say that I have some 1,000 followers, I have 10,000 followers, etc. So, or they may sometimes the children will correlate with the others. They see that they have got 1,000 likes, I got only 2 likes. That means my personality is not being liked by someone. So such type of thoughts also create a lot of stress among the children. And next thing is nowadays the series which are coming on Netflix, Amazon Prime, etc. These are all also causing lot of impact on the children and adolescents. They are showcasing every time like drug abuse or cigarette smoking, etc. They have normalized it in the movies also, even though they are giving a small line at the end. But every time you are producing some video or you are sharing something on a social media, you should be very clear that you are not portraying any negative message to the society. It is better that you are giving something which is very needful for the society. And next thing is address the risk factors. These are all the things what all the previous participant panelists has told, like address the availability of firearms or chronic illnesses, financial difficulties, negative life experiences, job loss or crisis, stress, sleep problems, and health issues, etc. And sometimes in hospital, schizophrenia patients are having hallucinations, especially the command hallucinations are very dangerous. So whatever it is, we have to focus is on the psychological first aid. And next thing is spiritual needs. Spiritual needs of the person really play a vital role. Because if we are going to a temple or to a church, we are praying, that means we are automatically gaining some energy. And also we have seen that in a meditation, if you are doing alone meditation, that has some impact. But if you are doing meditation in a group, that has more impact. What does it mean is these spiritual needs means we are coming together to share something with each other. And that is how we are going to build our relations. That is how we can have something that we have been cared and there is someone to share and we can talk with someone. So these play a vital role in a making support systems. And sometimes if it is going beyond our control, as in the previous printer, Kranti ma'am has said, when person has to be hospitalized, when they need only emergency contacts and when they need only self-care. So we have to identify and we have to plan our things accordingly. And next thing is coping strategies: exercise, reading books, movies, and going for tourism, etc. And apart from this, pharmacotherapy, psychotherapy play a vital role. Next is cognitive behavior therapy. Cognitive behavior therapy is nothing but our behavior will starts with our thinking. Means if our thinking is wrong, then we are going to have wrong behavior. So first thing is we have to change our thinking patterns. Next thing is effective follow-up after discharge and whom to contact in emergency. And sometimes we feel that it is a very small issue, but it may be a very big issue for other person. Always think that in the terms of opposite person, not in terms of ours. And next thing is let the person know that you are there and ensure that you are not alone. Active listening, non-judgmental attitude, and use open-ended questions and develop self-care routines before preaching to someone else. So this is how we can overcome the stigma to talk about the suicide and things. Next thing is need for mental health nurses in the primary care. This is the thing which is coming up in nowadays, community engagement program. Now all of you are listening to the presentations, all of you are having the knowledge. Now if you are just taking this knowledge and forgetting by today, that is of no use. So you should be able to engage your community. You should be able to share this message to the community. You should identify with whom I can share. With whom I can share means with how many persons I can share the message and how we can contact each other and then how we can solve each other problems. So for this, you have to identify the stakeholders like school teachers or some of the organization CEOs, and you can have some initial meeting with them and have some agenda, and then you make some plans and how we can present this type of topics in the society. So that is how we can reach to the maximum level. As nurses, we are working with patients and communities. Community nurses will have a vital role in making such community engagement programs. And these are some of the relevant interventions what we can see, and these are also some of our future plans. how we can reduce the stigma on suicide by engaging in relevant discussions as we are doing today. And next thing is training the community health workers, teachers, organizations, and public also. Next thing is promoting crisis support services like any helplines are available, and provide mental health awareness and skill training in the schools, integrating young people for peer support programs, and establish media communication protocols. Nowadays, media is projecting how they are also having some of the guidelines how to publish in a newspaper and how to show in a movie such type of incidents, which should not create any ideation things in the children. Next thing is setup of support for the bereaved families and those with live experience of self-harm. Next is respond to vulnerable groups after the suicide, create a directory, link, social services programs, etc. So when we are working with community, these are the questions we should ask. How we can overcome the stigma? How comfortable are we discussing the topic and the surrounding topics related to the suicide and prevention of suicide? And what all the resources are available, and how we are going to use that resources in this activity? So these are all the questions. These are all the research gaps. What we have found is till now there are no liability frameworks to protect the psychiatric practitioners and patients, and telehealth supported decision making is still in process. And migrants face a lot of stress because they are living out of their villages or cities, and they are having a lot of stress. So migrants are more prone for experiencing stress. So we have to we need more research studies related to migrant studies and suicidal ideations. Identify the data gaps. Is there any other things we need to do? So these are all the areas we can focus on the research. This is Mental Health Act in 2017. Its focus is promotion of mental health and preventive programs, that is promotion of mental health and prevention of mental illness in the country. And government shall in particular plan, design and implement public health programs to reduce the suicides and attempt suicides in the country. So for this, earlier there was section 309 IPC code. Attempt to commit suicide, whoever attempts to commit suicide and doesn't act towards the commission of such offense shall be punished with simple imprisonment for a term which may extend to 1 year. This was earlier, but after coming introduction of the Mental Health Act, now it is saying that it is presumed unless proved otherwise to have severe stress and shall not be tried and punished. Shall not be tried and punished. So Mental Health Act suggests that not to be punished. So this is what is there. And next thing is India's National Suicide Prevention Strategy, which is introduced in the last year. That is overall objective is establish effective surveillance mechanisms for suicide within next 3 years and establish psychiatric outpatient departments that will provide suicide prevention services through district mental health program. And in the next 5 years, integrate a mental well-being curriculum in all education institution within next 8 years. So this is how our India is planning the strategy for prevention of suicide. The main goal is to decrease the mortality of suicide, mortality related to suicide in the country by 10% by the year of 2030. So this is how we can do. We can reinforce the institutional capacities, enhance the capacities of individuals and organizations, and develop the community related activities, and we can strengthen the surveillance, etc. So these are all the references from which I have taken the presentation, and a small support from you is expected. Whenever you are forwarding something message in a social media, ensure that you are not forwarding any negative message or not creating any negative stress on the person. First thing, only share the positive things in your social media and also the way of talking. Next thing is we are going to announce a video competition on World Suicide Prevention Day. All the guidelines will be emailed to you by today or tomorrow. And at any point of the year, if you want to submit any health messages, if you are having any recordings, you can share to me and I can upload on my channel. And all of the video sessions of today can be uploaded on IAPH channel and World Explorer India YouTube channel. Kindly go through it. Thank you, all the panelists and participants. Thank you so much. Over to Melvin, sir.
Thank you, sir. Thank you so much for taking us and leading us towards the legal and other governmental related implementations towards the suicide prevention. And We had a wonderful talking today, and all the speakers, they had come up with their personal experiences and a lot of content in it. So we learned a lot, and apart from that, we received a lot of questions in the chat box, and I invite Ms. Simran, ma'am, to lead us, in the doubt clarification session. We've opened the forum and even will give the access to all the participants to unmute yourself and talk if you want in between. So meanwhile, we can clarify the doubts of those people asked in chat box. Ma'am, Simran ma'am, can you take over?
Yes, sir.
Yeah, please.
So, good afternoon to all the speakers and participants present here. As all the speakers have finished with beautifully sharing their ideas, thoughts, and experiences, so now the floor for questions have been opened for the participants, where they can ask the questions from the esteemed panel of speakers and can give their feedbacks regarding the webinar. So, can we start?
Yes, ma'am.
Yeah.
In the question answer chat box, various questions are asked by the participants. So some of the questions are, first one is asked by Mr. Amal B. Cause of suicide is one of the cause of suicide is peer group pressure. So how it can be managed? So Mrs. Kranti, can you please answer?
Hello.
Yes, ma'am. Ma'am, can you please
Yeah.
answer the question?
Yeah. Can you just repeat the question?
Repeat the question.
One of the major cause of suicide is peer group pressure and how it can be managed.
Yeah. See, peer group pressure can be. I mean, there are various factors in which sense the person is asking the question. I'm not very sure. But the peer group pressure can be for substance abuse. It can be for resorting antisocial behavior, or it can be for just to be in the group. Like I am part of that group, and that's why the group is performing in that particular way. That's why I have to be in that group, so I also have to be performing like the group. It is always there, the copy phenomena we say. But that's why we have taken the session that rightly, whenever you feel that you're not comfortable with peer group or with any idea, then you should assertively stand for yourself and say no, that I'm not comfortable doing that activity, or I'm not comfortable performing. The group says so, because the group says so, right? And then only we can in initial stages only we can prevent the suicidal ideation. I hope I have answered the question.
Okay, thank you, ma'am, for answering. So now the next question is asked by Mrs. Meera. And the question is, apart from counseling, what other methods can be used to prevent suicide in young population? So, Mr. Kurva, sir, can you please answer it?
Yes, ma'am. As in young population means right now I have discussed very clearly in my presentation that what is causing stress among the young population. Is it the social media, or is it the educational system, or is it the family cultural values, or is it peer pressure? So we have to identify what is causing the stress for them. And next thing is we should be able to develop the activities of self-care. Means we should be able to identify what is right for us and what is wrong for us. We should not be we should not be depend on others for our own decision. I mean to say that as a child, if you are giving them enough of resources, that how should you be speak in such situation, or what to do in such situation, if you are giving all the information to them, the thing is information again, which information is right and wrong. Nowadays internet is with full of negative information. So what is right and what is wrong, we have to identify, and we should provide right resources to the children, and then children are able to take their own self decisions. And apart from this, we have to decrease majority of the stresses among the children. Like if some of the topics they are not able to speak, so all other peers can come together and speak to themselves. And we need to create some social spaces And if something is going wrong, there should be someone who is more experienced. They should come and intervene immediately. And next thing is they have to know when they should approach a counselor. And if they are knowing that, then they can immediately go to a counselor and they get a psychological first aid. And next thing is what I suggest is every school is nowadays having a school counselor, and also in forthcoming years in primary health center also mental health nurses will be recruited soon. Maybe that will bring a lot of changes in the society. So this is how I can answer. So much.
And here again,
Okay,
sorry
thank you.
for the intervene, Simran. See, here again, I wanted to tell something, add up to the Sarah's point, especially when we are focusing on a young group. The social media is a major influencer among them, and now we cannot stop growing the technologies. And even the parents, they can have a control over the children by understanding the technology. I could say, like, parents should understand the technology clearly. We have to educate them, because in every, the most commonest way of accessing the social media is through mobile phone. I hope so. So we have to have a parental control. So the in technology itself, the mobile phones nowadays, it can be an Android platform, can be a iOS, whatever it may be. It comes with the parental control, and parent can restrict the children what to see in their mobile. And even they can put a timeline, like only per day this many hours can be used. Only these are the sites they can go for it. These are the, if it is a YouTube, these are the channels they can go for it. So such kind of monitoring and control can be done, so that the majority of the problem can be reduced, I hope, among the children, especially when you are dealing with the social media and technologies. Because we have to have a better understanding. We cannot stop using technology. Because of a technology only we all connected in this time also. So we have to identify these technologies a positive manner. For that, we should know it first of all. So we should understand it, then we should make it more positive. That's what I wanted to add up in this point, especially in terms of children and related thing. Thank you.
Okay, thank you, sir. So the next question is, what are the warning signs for suicide? This question is asked by Ms. Akshata. So any one of you can answer regarding it.
Shall I
Hello.
say? Shall I take it, ma'am? Yeah, Kanti ma'am, please carry on. Okay, no problem.
Sir, please take forward.
When it comes to warning sign, definitely they will not give hints. It's very difficult to get those cues of warning signs, because they will be happy today. Many things we will see, we will experience that. Today they are very happy, they are very engaged, they have celebrated a party. All of a suddenly, tomorrow morning, we will see that he is no more, or he or she is no more. The same thing, because the cues are very difficult. It can be identified only if you are very closer to them emotionally. To get into the emotional closeness, it requires you as a tool, either a therapist or a friend or a parent or a teacher or a counselor, whatever may be that different. That's the reason it is said that as a peer or a friend, he is the first therapist. So that's why it's only can be identified the person. There is a requirement of peer group strategies. The peer, the friend, is the first person to identify the cues. What is that cues that they will give is, first thing they will start saying that, they will say that, yeah, they will write a letter, they will not disclose. Second thing, they will settle that issues, whatever the dues that they had, they will pay up their loans. They will go and meet their elders, youngers, parents, whomever they love very much. Then they will make efforts to settle the conflicts, whatever they had in the past, so that that guilt is not there. And they will give away, distribute that whatever the property that they have to the children or whatever, whomever it may be. and after finishing that, these are all, one is morbid thing, there is non-morbid thing. The morbid thing is different, that they will say, I am very sad, I am very depressed, I am getting commanding thoughts which are commanding to commit suicide. These are all morbid thoughts because of illness. There are, apart from these morbid thoughts, they will definitely do all these behaviors to settle everything. Then at last, they will be very happy. See, a person who is sad for the past 15 days and who is happy on the last day, a day before attempting suicide, which gives an important sign. Many patients we visit, they will be very happy. Whenever they visit with happiness, it is not so good sign. We will miss that. You will see that, yeah, he is happy, that means he is improved. No, he has made up that plan and he is going to implement that plan. This cue is very important. So if we address these cues, morbid and non-morbid, and the cues which are nearing to the suicide, committing suicide, it will definitely help everyone to prevent suicide. Thank you. I hope I got into the content of it.
Very well spoken, sir. So the next question is, what are the societal risk assessment tools? Ms. Kranti ma'am, can you please answer?
There are 2 or 3 tools available in the market. One I've already shared, Columbia Risk Assessment Tool, and there is another Societal Risk Assessment Questionnaire is there. But the previous one is more extensive. That's why we prefer using Columbia Assessment Tool rather than the questionnaire.
Okay, thank you, ma'am. So the next question is, what is the role of nurse in suicide prevention? So, Mr. Pal Vinay sir, can you please answer it?
Role of nurse, in various settings, it may vary. To keep it to general context, a person visiting with a general hospital, definitely that we will not be thinking about psychiatric illnesses, whether they will be having these thoughts or not. Especially with terminal illnesses, cancer, patients with young age, children are suffering from various illnesses. The parents would be that target population where they are at risk. So, based on, when it comes to psychiatric illnesses, we have already come across with many things. The focus of nurses when they are not in psychiatric areas, they are working in general health setups, especially pregnant women, divorced, marital discord, issues related to addictions, where patient comes for treatment of addiction diseases. When there is a history of general hospital, that they will come with a suicide attempt, any cut marks over hands, ligature marks on the necks. So these things in general has set up, nurses should be focused on these cues so that we can prevent many things. Because when it comes to psychiatric setup, definitely with experience, definitely they will be able to handle these things. But it should be focused should be on non-psychiatric setup, where we will be able to handle and understand that cues of attempts or future plan of attempting suicides. Thank you.
Okay, thank you, sir. So the next question is, heavy studying pressure leads to suicide. How it can be prevented, and why more suicides occur in males as compared to females? So anyone can answer it?
I think Kranti ma'am can answer, because madam said, like, males are more tend to.
So not being judgmental. Yeah, regarding study pressure, I first answer the question regarding study pressure. See, if there is a class of 100 students, and out of 100, why only one person is feeling the study pressure? Because everyone is undergoing the same say syllabus. Everyone is preparing for the same examination in one particular class. That itself gives idea that one particular person, whoever is feeling the pressure of studies, has some risk factors, say low self-esteem or lack of preparation for the curriculum, or say other risk factors. Say some person is ill in his or her family, the person is already having other burden from family or from other financial issues. There are some of the other risk factors always present, which predispose that person to study pressure which he or she is feeling. Then we have to identify those risk factors and deal to minimize their risk. As sir has rightly said, the minimizing the risk would result into prevention of suicidal behavior actually. And the other question was regarding why males feel, or why males get suicidal ideation more as compared to females. Yes, it is. Statistically, it is seen. The studies have shown that males, especially in adult males, from 30 to 55, 59 years of group, are more prone to commit suicide or more prone to actually conducting suicidal behavior than the females, because maybe for Indian perspective, I would say, because of Indian family system is such that the parent or male figure is entitled to carry forward maximum burden of the family. And suppose the family, the male is not able to provide or lacking somewhere, the male himself takes it on his ego, and his societal status may be disturbed. Or uski friends will only say, why you're doing so, you're not able to do this much in this particular month, you're not able to achieve your goals, whatever the task is being assigned to you by your manager. The peer pressure creates the environment, and that's why maybe males, and of course males have more professional groups, they are more into talking to friends than the females. This is actually environmental factors. There are intrinsic factors also, especially males are not very much comfortable talking to their partners regarding their emotional dilemmas or emotional situations. They for example, suppose a lady is experiencing uh, low mood since say 1 week, she will directly first option would be husband to talk to. For a lady, she will talk to her husband or a partner. But suppose the same case is happening with the male, other counterpart, will he consider talking to the partner immediately within 4 to 5 days? I don't think so. He will not be. He will rather talk to friend or talk to someone, or not talk at all, unless and until he feels that it is now going out of our hand. That maybe these are the factors which predispose males more as compared to females.
Yes, ma'am, I want to add some more thing here. Here we see nowadays that if woman is crying in public, it is okay. But if man is crying in public, it is not okay according to society. So these are all the gender stereotypes which we are having. So when we overcome such situation only, it will decrease. So culture plays a vital role in this. So we have to overcome those barriers for this.
Yes, sir has rightly pointed out cultural differences.
Okay, thank you, sir and ma'am. So the next question is, what are the legal aspects to be kept in mind while taking care of the suicidal cases? Mr. Kuruva, sir, can you please answer it?
Yes, ma'am. As a nurse, when we are working with in psychiatry unit, or it may be in a hospital, now we know all the risk factors of suicide. Now we know who is at risk of suicide, who is so our responsibility is to decrease the incidence of suicide. So what we try to do is we try to follow up with the patient, but unfortunately if the patient has got inpatient suicide, that is very dangerous. Means we are the one who is taking care of a patient, but we are not able to protect the patient. So even though we know that we are removing all the things from the patient, even though we have tried our level best, but patient has got suicide. So in such cases, it may end up in legal issue, and even it can become a medical legal issue. So our responsibility is to make an incident report, how it happened, where it happened, what happened exactly. So first thing is incident recording, and next thing is informing the appropriate authorities, and next thing is, are we authorized to talk to family members or not? Is there any spokesperson in the hospital? Are they only allowed to speak to family members and media? So all these things we have to keep in mind. So as a nurse, we should be very well aware of medical legal issues, and we should be able to deal with such situations. Thank you.
Okay, thank you, sir. The next question is, many adolescent students are prone for suicide and guardians are scared to punish them, and so how can they manage it? Mrs. Kranti ma'am, can you please answer it?
I actually did not get the question.
The question is, many adolescent students are prone for suicide and the guardians, whether it may be parents or teachers, are scared to punish them. So how they can manage this situation?
See, you mean to say this is again a case of impulsive behavior. For example, when we were children, teacher used to scold us if we have not done our homework, or if we have not finished our assignment or project. Teacher used to scold us. Nowadays what is happening is there is there are two-way factors, you can say. Teachers are scolding, or it is their right, or it is their responsibility to get the work done from the student, but teachers are not not hitting as per se, only scolding, and that too up to the age of say 11 or 12. Later on, that later 12, post 12 years of age, I don't think the teacher is actually scolding ki क्यों नहीं किया आपने homework, ऐसे कैसे नहीं किया. No teacher scolds like that, because nowadays you can see puberty comes at earlier. So bacha still needs to feel that he has his say, he has his opinion valued. So in assertive way, the teacher can say that you has to, the teacher can, what teacher or parents can do, they can make child responsible for their own actions. See, if you will not do your homework, or if you will not do your assignments on time, it will result into your lack of expertise, or your you will not get insight into that particular topic, and which will eventually is going to affect your grades. So in that manner, the caregiver or teacher can explain the thing rather than scolding. And if at all the teacher scolds, it is the need for the hour. The student, on part of student also, there should not be impulsive reaction to the stressor. The scolding can act as a stressor, but teacher can scold to a whole class. The whole class is not going to commit suicide, or whole class will not think of not attending the class ever again. Why the one person will only think? Because there are some other predisposing factors which we need to look after, and then the mitigate the factors.
Okay, thank you, ma'am. So the next question is, in villages, what are the ways how we can prevent suicide for children? Mr. Binujoy, sir, can you please answer?
Ma'am, Benu sir is not available. Can you tell Vinay sir to answer?
Yeah.
Um,
Shall I take?
Yes, sir.
Shall I take this, ma'am?
So the question is, in villages, what are the ways we can use for prevention of suicide in children?
We have been talking about minimizing risk factor. On the other way around, how can we promote protective factors? When we think about how to protect, we have to ensure that we are, there is a different thing. See, if we minimize risk factors, it is definitely, it is the opposite way. It is disproportional. The protective factors will increase. Rather than minimizing the risk factor, we have to ensure that how to improve protective factors in villages. See, what are the protective factors? We have nearby parents, we have close relatives, we have people around, we have grown together, we have old friends, we have buddies, they have grown with us so many years. So we have teachers, They have seen our growing with minimum like basic education, elementary education. They have taught us. We have many social systems around. We are socially actually connected in villages rather than in urban areas. We have been celebrating many social programs, cultural programs, village. We have been celebrating village programs together as a only village. We will celebrate many carnivals. So we have to ensure that village should also promote an atmosphere in increasing protective factors in this context. So we have panchayat systems which will work in protecting, ensuring that children are safe, adolescents are more safe. Which age group at risk? There should be a system to analyze which areas are more affected. So definitely, village is a good place. We have to focus rather than minimizing risk factor. We have to focus on enhancing the protective factors that will definitely benefit in village setup where promotion is more focused because it has less because we cannot invest time, we cannot invest resources of money in village setup. Definitely, whatever we have, we can increase resources. Thank you.
Thank you, sir. So now, as all the questions has been answered, so thanks to all the speakers who have patiently and promptly answered the questions of the participants. And I will thank all the participants who gave their time and all the speakers who gave their precious time to answer the questions. Thank you to all.
Thank you, ma'am. It was a wonderful discussion. There are a lot of questions in the chat box I could see, and we respect all the participants who raised the questions, and still any leftover, and we can answer through the mail, and even will be late in the evening or by tomorrow we'll be uploading it all the videos, different speaker sessions in the YouTube channel, and that will be shared with you all through mail. Please check your mail regularly, so we will send all these things. And at the end, I invite Ms. Ishurani to propose the vote of thanks. Ma'am, please.
Good afternoon, everyone. I, Ishurani, Assistant Professor, Chitkara University, Baddi, Himachal Pradesh. It is such an honor for me to get the opportunity to thank you all the speakers and delegates. I would like to express my gratitude to all the esteemed delegates of the webinar for their presence and contribution to make this webinar a great success. I must thank the Innovative Alliance for Public Health in association with Nursing Scholar Society, Chitkara University, Baddi, Himachal Pradesh, Mind and Sex Clinic, and World Explorer India YouTube channel who invite us to the e-webinar on creating hope through action in celebration of World Suicide Prevention Day. I would like to thank Organizing Secretary Mr. Melvin David, Assistant Professor, PES College of Nursing, Mr. Vinu Joy, President Nursing School Society, Mrs. Gagan Sharma, Associate Professor, Chitkara University, Baddi, and Mr. Vinay Kumar, Senior Nursing Officer, NIMHANS, Karnataka, Mrs. Kranti, Child Psychologist, Mind and Sex Clinic, Nagpur, Mr. Purva, Nursing Officer, IAPH member, and Ms. Simran, Nursing Tutor, Chitkara University, Baddi, Himachal Pradesh, for working hard for the past few days to make the webinar successful. Thank you everyone once again for making it a great success. Thank you all.
Thank you, ma'am, for your vote of thanks, and we thank for your your presence in here in this meeting. And we have given access for all your camera, if possible. All the participants, can you turn on your camera so that we can take some remembrance screenshots? So it will be good, I hope. So we have given access to all the participants as well. If you could able to turn on your videos and we can take some snaps. The participants. Thank you all.
Thank you everyone for providing this opportunity. Thank you, Melvin
Thank you,
sir.
ma'am. Thank you, ma'am. Thank you so much.
Thank you, Vinay sir.
Thank you. Thank you all the participants for your
Thank you.
patient listening. Hope we all had a wonderful session. Thank you. Thank you so much.
Thank you, sir.